go on to our next speaker, Dr. Durga Priyadarshini, and she's a practicing neuro-ophthalmologist at Shankar Nethralaya, again a very knowledgeable person, and she would be talking on cerebral visual impairment, when to suspect and how to manage. On to you, Dr. Durga.
Thank you, ma'am, for your kind introduction. I'm just sharing my screen. Is my presentation visible?
Yes, yes, yes.
Yeah. Thank you, Dr. Chitra ma'am and the ARC team for giving me this opportunity. So my talk is cortical visual impairment, when to suspect and how do I manage. So let me start with the case. 59-year-old male came with a complaint of left eye sudden drop in vision a week back. He gave a history of CABG 10 years back, and he had recovered from COVID-19 infection 10 months back. On examination, his vision was 6/9 N6 in both the eyes, and slit lamp examination had a NS2-3 compact cataract in both the eyes. Pupils were reacting to light. The color vision was intact. Fundus examination was absolutely normal. So I was almost about to advise him cataract surgery, but felt that something was not okay. So I went back to the history and found that the red flag here was a sudden drop in vision a week back. So I advised the patient to undergo a visual fields, which picked up a left-sided complete homonymous hemianopia, and the MRI picked up an acute infarct on the right-sided PCA territory. So moving on to the talk, cortical visual impairment is due to the lesion along the visual pathway posterior to the lateral geniculate body. Most common cause is a posterior circulation stroke, and recognizing it leads to proper management and improved outcome. So let's see them. So going on to the etiology, in adults, the most common etiology is the CVA, trauma, electrolyte imbalance, infections, or transiently in encephalopathy, they can be seen. In pediatrics, the most common cause is perinatal ischemia, periventral leukomalacia, trauma, tumor, or congenital causes. In pathophysiology, let's go through a little bit of anatomy. It's a geniculocalcarine pathway which starts from the LGB to the visual cortex, passing through the retroretiform part of the internal capsule. The Meyer's loop, which carries the inferior fibers traversing anterolaterally and anteroinferiorly along the temporal horn of the lateral ventricle, and synapses into the temporal lobe and synapses with the anteroinferior border of the calcarine sulcus. Whereas the posterior bundle carries the superior fibers, travels posteriorly along the occipital horn of the lateral ventricle into the parietal lobe and synapses with the superior lip of the calcarine sulcus. The visual cortex, which is the end organ of the efferent visual pathway, receives the input from the LGB. The right and the left visual fields are represented within the left and the right occipital lobe, respectively. The upper bank of the calcarine sulcus receives the superior retinal fibers, whereas the lower bank receives the inferior retinal fibers. 55 to 60% of the visual cortex has the macular projection, and the foveal projection is the tip of the occipital lobe. Anterior striate cortex has the monocular projection subserving the temporal 30 degrees of the visual field in the contralateral eye, and representation of the vertical meridian is along the lips of the calcarine sulcus. Going on to the blood supply, the optic radiations receive the blood supply from the anterior choroidal artery and the deep branches of the middle cerebral artery and the calcarine branches of the posterior cerebral artery. Whereas in the visual cortex, the majority of the blood supply is from the posterior cerebral artery, and occipital pole has dual blood supply because of the anastomosis, good anastomosis between the posterior cerebral artery and the branches of the middle cerebral artery. Next, let's look into the signs and symptoms of the cortical visual impairment, and the most common is the visual field defects seen in these patients, and there can be a variety of visual field defects. Let's see one by one. The unilateral occipital lobe lesion can has a contralateral homonymous hemianopia, and mostly they are congruous because they are posteriorly located. And macular sparing can be seen in isolated PCA territory infarct because of the dual blood supply. Homonymous hemianopia, central scotomas can be seen in tip of the occipital lobe lesion, and monocular temporal crescent seen in the contralateral anterior striate cortex lesions. And then they can have keyhole visual field defect if there is a bilateral PCA territory. In fact, here you can see there's a step-off defect which respects the vertical meridian, and this helps in differentiating between the other causes of constricted visual fields. They can present with quadrantic field defects if there is restricted lesion on the either upper or the lower bank of the cortex, and classical checkerboard field defect can be seen if there is one side upper bank involvement and the other contralateral lower bank involvement. Next is the cerebral blindness, where the patients have the reduced visual acuity and they can have any level of visual acuity, but usually they are symmetric. if there is asymmetric vision loss, then look for a suspected anterior visual pathway involvement in these patients. The pupils will be intact in cortical blindness, and they have a normal fundus examination. The cause is usually bilateral retrogeniculate dysfunction. The cortical blindness can have Anton syndrome, which is visual agnosia or denial of blindness when the lesion is in the V1 area. Redoch phenomenon is nothing but the statokinetic dissociation is another presentation where they perceive moving objects in the blind area, which is thought to involve the V5 area bypassing the V1, leading to awareness of the motion within the blind field. If there is proximal PCA occlusion, they can have midbrain involvement and extraocular movement abnormalities. And the Kogan's dictum states that homonymous hemianopia with asymmetric O'Kane localizes to the parietal lobe lesion, which is most likely to be a tumor. And if there is symmetric O'Kane associated with homonymous hemianopia, it localizes to the occipital lobe lesion. Upper bank occipital lobe lesion can present with Bellin syndrome, which includes optic ataxia, oculomotor apraxia, or sebeltegnosia. And if there is lower bank occipital lobe lesion, they can present with prosopagnosia, hemiachromatopsia. Moving on to the evaluation and management, any patient with homonymous hemianopia should have a neuroimaging, preferably an MRI, and attention to stella and tract is important if there is associated optic atrophy or relative efferent pupillary defect. Look into the vascular anatomy by asking for MR or CT angiogram, and if MR and CT is inconclusive, think of functional MRI. PET or SPECT technique can demonstrate hypoperfusion in the visual cortex areas in patients with unexplained field loss. In blood workup, ischemic workup is advised. Do an ESR and CRP if you're suspecting giant cell arteritis. Vasculitis and coagulation profile has to be done in young patients who had a CVA. And if you're looking for a cardiac source, ask for an ECG, echo, or a Holter monitoring. Extracranial carotid artery evaluation can be done by doing a carotid Doppler or MR angiogram of the neck. Moving on to the treatment, the primary treatment is treating the cause. Most of the time it's a stroke, so they need an urgent referral to the neurologist or the vascular surgeon. And visual rehabilitation is very, very essential in these patients. And there can be 3 approaches in visual rehabilitation, which includes restoration therapy, substitution therapy, and compensation therapy. In restoration therapy, researchers are investigating how to optimize the visual training to attain the visual recovery. And one of it is home-based computerized therapy, where repetitive stimulation at the border of the visual field defects are being done, and they are telling that they do have benefits in reading and watching TV, but it's highly controversial. Still, people believe that, experts say that neuroplasticity is unlikely. So further studies are warranted to show how visual rehabilitation actually works. In compensatory therapy, it acts by compensating for vision loss by saccadic eye movements and head movements. Patient needs training on saccadic movements and also head scanning technique. Here we see a patient doing a vision therapy in Senet Vision Integrator. Children usually develop compensatory mechanism like exotropia or head turn towards the intact visual field side. In substitution therapy, it's either the prism or other devices are used to project the visual stimulus from the non-seeing side to the seeing side, like in hemianopic glasses, where a basal prism is placed on the temporal half of the eyeglasses. So ipsilateral to the hemianopia, where the visual stimulus is reflected to the seeing side.
1 minute remaining.
Other glasses are ground prisms, yoke prisms, and Pele prisms are being tried. Newer digital devices are also coming up now to overcome the limits of the prism glasses, though they are not available in India at present. So to conclude, cortical visual impairment can cause severe morbidity in the affected patients and their family. So early detection, treating the cause is usually life-saving. History taking is a key here in these patients. If the symptoms are not matching with your examination findings, kindly further evaluate the patient, ask for a visual field or a neuroimaging. Early initiation of rehabilitation therapy actually helps in achieving benefits in their day-to-day life. Thank you.
Thank you very much, Durga. That was a very extensive, thorough talk. We'll just take one question. Murli, you can ask before we move on to our next speaker.
Yes, madam. I have a question, Dr. Durga. That is, how useful do you find this OCT GCC? Some of these patients are not able to cooperate for visual fields or do not give a reliable visual field. So have you found like OCT GCC to be of value as it is in pre-perimetric glaucoma, or like it is just complementary and not of that much value? You would still rely on visual fields?
I would rather go for a confrontation test than OCT. I don't know. In pertaining to the retrochiasmal involvement, how far OCT is going to help, I'm not sure about it. But I feel if they are not cooperating for a visual field assessment, I would prefer to do a confrontation test in them.
Yeah, there's a question on the chat box, madam, for the expert panel, particularly for Dr. RAG and Dr. Rohit. That is EHARA color vision testing enough to diagnose ethambutol toxic optic neuropathy, or do you need to test blue color vision deficiency specifically?
So in general, you would have, it's not so specific kind of color deficiency. And red-green is among the early ones that pick up. In fact, your suspicion can be aroused just on a general color effect. So if the patient is able to appreciate that there is a reduction in his color sensitivity is good enough. And EHARA is fairly sensitive to pick up any color deficiency. So I think short of if you want to actually ease the testing in a wider population, it would be better that EHARA would be used as a quick screening test to pick up subtle defects. And maybe if you have subtle defects on a patient on ethambutol, you would then want to confirm by either a VP, which would show you optic nerve damage, which would be more confirmatory.